Good morning, everyone. I am a nephrologist at the Brigham Women's Hospital in Boston, an instructor in medicine at Harvard Medical School, and I am going to present some board review practice questions today. There's quite a diversity of questions here across all kinds of topics. Some of the answers may be a little controversial at times, but we're all going to learn something from these questions and answers. A little bit about myself. I graduated from University College Cork in Ireland and did my residency in Bowman Hospital in Dublin, and then came to the US to do my fellowship at the Brigham, where I had stayed on as a staff member for the last 10 years. I am interested in ICU nephrology and lupus nephritis, and I am also very interested in postgraduate education, and I'm involved in a couple of lupus trials. For disclosures, I'm doing some research with Alexion Pharmaceuticals, and I act as an advisor and consultant for Alina Pharmaceuticals and Advanced Instruments. All right, let's get to the questions. An 82-year-old female with type 2 diabetes mellitus, hypertension, hyperlipidemia, and chronic kidney disease with a serum creatinine of 2.3 is exertional chest pain consistent with myocardial ischemia. Her stress test is positive. Prior to cardiac catheterization, she is given intravenous fluids and N-acetylcysteine to prevent contrast nephropathy. The left anterior descending artery is stented, and she is started on clopidogrel. Approximately 4 days later, she develops oliguria, azotemia with a creatinine of 2.8, abdominal pain, and is evidence of GI bleeding. Which of the following is the most likely cause of the AKI? A. Cholesterol embolization to the renal arteries. B. Prerenal azotemia. C. Ischemic tubular necrosis caused by hypotension during catheterization. Or D. Radiocontrast-induced nephrotoxicity. The answer here is A. Cholesterol embolization to the renal arteries. The thought here really would be whether this might be due to her catheterization or whether it might be due to another cause. It is unlikely to be related to catheterization, in large part because it is too late after the onset of, after the procedure itself. If contrast-induced nephropathy was going to occur, and it is relatively rare these days, thankfully, it would generally occur in the first 48 hours after the contrast administration, whereas this developed 5 days later. Embolization, in contrast, can happen much, much later. From cholesterol emboli. In her case, her AKI occurred at 4 days post-catheterization. She had abdominal pain, fever, and GI bleeding, which was suggestive of cholesterol embolization to other sites as well, the kidneys. Other signs and symptoms you might see include peripheral eosinophilia, decreased complement levels, and lutose consistent with emboli in the periphery also. The sediment may be active, may also not be active. The diagnosis is made by doing a kidney biopsy. And what you actually see on a kidney biopsy is the so-called cholesterol cleft. What happens in these individuals is you have cholesterol emboli, which go into the small vessels in the kidney, block those vessels, and then cause an inflammatory reaction, which ultimately causes the progressive kidney disease that you see. And this is why it generally occurs over a longer period of time, because although there's a small amount of injury that occurs due to the embolization itself, it's the inflammatory reaction to the emboli that causes the more chronic injury. And the reason we call it a cholesterol cleft rather than seeing the cholesterol itself is because the cholesterol is removed during processing of the sample. So what you see is an area or a empty area where the cholesterol would have been before, very characteristic so-called cholesterol cleft. All right, question 2. A 25-year-old woman with no significant history is referred by her PCP for a new onset hypertension. On exam, she's a thin female with normal heart and lung exam. There is no edema and her exam is otherwise normal. Blood pressure is 190/95 and equal in both arms. Her urinalysis was normal and her labs were notable for a creatinine of 1.2, potassium 4, and a bicarbonate of 24. She denies intake of over-the-counter or prescription medications, and her family history was unremarkable. What is the most appropriate next step in workup of her hypertension? A. No additional testing. Secondary hypertension is unlikely. B, 24-hour collection for catecholamines, C, renal artery imaging, or D, genetic testing for Gordon syndrome? The answer here is D, renal artery imaging, looking for some kind of stenosis of the renal artery. The follow-up question is, renal MRI and MRA is ordered and shows the following, which is the most appropriate next step in the treatment of this patient's hypertension? A, renal artery bypass, B, renal artery stenting, C, renal artery angioplasty, or D, ACE inhibition. The answer here is renal artery angioplasty. This is a young woman. She's in her 30s. She has severe early onset hypertension, which is very suggestive of secondary hypertension. The abrupt onset is also very suggestive of secondary hypertension, and so she should absolutely have a workup. Gordon syndrome, which was answer 4, is an activating mutation in the thiazide channel. It's unlikely at onset in the 20s. Is also not suggested by the absence of familial history or hyperkalemia. Renal artery stenosis is the most common cause of secondary hypertension and may be present in about 40% of patients with malignant hypertension. The most common cause of renal artery stenosis in young women is fibromuscular dysplasia. The typical imaging appearance, just as we saw on that CT angio, is the string of beads. It responds really well to native angioplasty with a low risk of recurrence, although it is important when you are imaging them to make sure that they do not have any other stenoses in other large arteries, as it can be a systemic condition. Pheochromocytoma was much, much less likely. There's a triad of episodic headaches, sweating, and tachycardia, although many don't have all three symptoms. For fibromuscular dysplasia, the onset is generally before 35. It's associated with a sudden rise in blood pressure, an increase in creatinine, hypertension, headache, neck pain, and potentially a cervical buoy if they also have carotid disease. Other symptoms can include flank or abdominal pain, abdominal bruit, transient ischemic attacks, and strokes. Question 4. A 43-year-old male construction worker presented after being found at home lethargic and confused. He was last seen in good health approximately 12 hours earlier. He was afebrile with a blood pressure of 102/55 and tachycardia. He was arousable with lethargic and confused. His respirations are shallow. His lungs are clear and his abdominal exam is benign. His neurologic exam is non-focal and the physical exam is otherwise unremarkable. His labs and studies are notable for the following: normal white cell count, sodium 141, potassium 4.2, chloride 102, bicarbonate 12, implying a pretty elevated anion gap. His BUN is 44, his creatinine is 1.5, his glucose is 122. His urinalysis has a pH of 5.5, negative ketones, trace proteins, and rare red cells and white cells. Head CT and chest X-ray are normal. What is the best combination of tests to determine the etiology of this patient's syndrome? A, lumbar puncture, blood and urine cultures. B, blood gas and urine toxicology. C, blood gas lactate levels and serum osmolality. Or D, methanol and ethanol levels. The answer here is blood gas, lactate levels, and the serum osmolality. A is this patient potentially has an infection, and it certainly could be a cause for the metabolic acidosis, but it will be important to establish first, before looking for an infection, what the cause of the acidosis is. So I would not do A. It would certainly be part of the workup, but wouldn't be the first test I would do. Blood gas and urine toxicology might actually be helpful also in trying to determine what the ultimate cause of this is, but it's not likely to return fast enough to be able to tell you, to direct how you're going to do your next steps in your management of the patient. Similarly, methanol and ethanol levels, they will be part of the workup because we need to rule out post-methanol and ethanol intoxication, but it would not be the first step because we still haven't established that the patient has an osmolar gap. So I would do a blood gas, lactate levels to rule out a lactic acidosis, and a serum osmolality to make sure that there is still measured osmol. This patient has an anion gap of 27. And so we need to think about the differential for an anion gap metabolic acidosis, including lactic acidosis and toxic alcohol ingestion. 1 hour later, the patient's wife is reached. She states the patient had been depressed lately and she found an empty bottle of antifreeze in the kitchen. What is the appropriate treatment for this patient? A, ethanol, B, CVH, C, dialysis, or D, dialysis and fomepizole. The answer here is dialysis and fomepizole. Ethanol might be a treatment for this if we did not have access to dialysis or fomepizole in order to decrease the conversion of the toxic alcohol to its more toxic acid, but it's not necessary where you have more advanced therapies. CVH is potentially useful, but it will generally be too slow at removing the toxin. So definitely we need to do dialysis in this patient. And I would add fomepizole to also aid in the prevention of conversion of the toxic alcohol to its more toxic acid. So the dominant features in this presentation are mental status changes in a positive anion gap acidosis without an obvious infection. And this should really raise flag for the possibility of ingestion. The blood gas will confirm the presence of acidosis. A lactate level will rule out lactic acidosis as a cause of acidosis, and measuring the serum osmolality will allow rapid calculation of a serum osmolar gap. A gap of greater than 20 is suggestive of some kind of toxic alcohol ingestion, including methanol, ethylene glycol, or isopropyl alcohol. It is important, though, to remember that only methanol and ethylene glycol will cause this degree of anion gap acidosis in the absence of ketones or lactate, because isopropyl alcohol does not cause an anion gap acidosis. And the reason it doesn't do this is because when it is metabolized, it's metabolized to acetone, which is also a small molecule which is not charged. And so the osmolar gap will continue to be elevated, and there will be ketones in the urine. There will not be any anion gap acidosis. Methanol levels and ethylene glycol levels are often not measured locally, so the turnaround time might be too slow to use in rapid decision-making. Whereas suspicion of an ingestion is moderate or high, dialysis and fomepizole may be initiated on the basis of the elevated osmolar gap and unexplained anion gap acidosis alone while waiting for methanol or ethylene glycol levels. Ethylene is metabolized to glycolic acid, which causes severe nephrotoxicity, and methanol is converted to formic acid, which has a significant neurotoxicity. The osmolar gap is produced by the ethylene glycol and not by glycolic acid. This is really important to remember as well. If you take an ingestion and you immediately measure the anion gap and the osmolar gap of ethylene glycol, for example, the anion gap will be normal and the osmolar gap will be extremely high. And this is because the ethylene glycol has not yet been metabolized into glycolic acid. Similarly, if you wait long enough after the ingestion, the osmolar gap could be normal, but the anion gap could be extremely high. And that is because all of the ethylene glycol is now being metabolized into glycolic acid. So it's really important to know the timing of the ingestion when you're interpreting results. CVH will remove toxic alcohols, but much more slowly than hemodialysis. And so really prolonged hemodialysis therapy is a treatment of choice for rapid reduction in levels. And this is even in patients who are hemodynamically compromised, in which case you should give pressors in order to maintain the blood pressure. The indications for dialysis and fomepizole include a pH of less than 7.3, renal failure, an ethylene glycol level of greater than 50, or a methanol level of greater than 50. Question 6. A 68-year-old woman with end-stage kidney disease secondary to diabetes and hypertension is on maintenance hemodialysis. Her current medications include aspirin, atorvastatin, insulin, lisinopril, which is help hemodialysis, erythropoietin, pasopril, calcium acetate, and weekly iron sucrose. On her pre-dialysis exam, she generally has basilar rails, 2 plus peripheral edema, and a blood pressure greater than 150/80. Her intradialytic weight gains averaged 2.5 kilos, and her dry weight is listed as 72. Noting that she looks volume overloaded and is hypertensive, the nephrologist asked nurses to change the dry weight to 70 kilos in an attempt to remove edema and achieve clear lungs. Over the course of several weeks, the patient has repeated cramping and intradialytic hypertension and is unable to achieve a weight below 72. She currently receives 4 hours of dialysis with sodium modeling, 145, 140, and 135. Her blood flow is 400 and dialysis flow close to 800. What is the most appropriate next step in this patient? 1, change the dry weight back to 72. 2, give albumin infusions during dialysis. Change dialysis orders to 1 hour of ultrafiltration followed by 3 hours of dialysis, or cool the dialysate to 35 degrees. The answer here is to cool the dialysate to 35 degrees. Intradialytic hypertension is a very, very common complication of dialysis that occurs in 20 to 30% of treatments and is a repeated issue in a subset of patients. Frequent intradialytic hypertension is associated with a high risk of long-term morbidity and mortality. There are many different causes, including impaired catecholamine release and end-stage kidney disease, autonomic neuropathy and impaired vascular tone, increased adenosine levels, and of course, reduced myocardial contractility in patients with any kind of heart failure. There are a number of different treatments which have been trialed for intradialytic hypertension: cooling the dialysate, sodium, which causes vasoconstriction, sodium modeling in order to keep the sodium levels higher at the beginning of dialysis, ultrafiltration profiling, where you do different rates of ultrafiltration at different times during the dialysis session, albumin infusion, blood volume monitoring, high calcium dialysate, which of course has its own issues, isolated ultrafiltration, abdominal band or raising the legs to increase venous return, adenosine antagonists, which are not available in the US, and midodrine and vasopressin. Clinical trials support the efficacy of cooling the dialysis, sodium modeling, the abdominal band, midodrine and vasopressin, and adenosine antagonists. Isolated ultrafiltration and albumin infusions appear to be relatively poorly effective. But the cool dialysate is well tolerated by most patients, stepping down to 35 degrees Celsius, and it may actually improve myocardial perfusion contractility. And so this is the best first step here. Sodium modeling is helpful in raising the blood pressure, but the problem is that it causes relative hypernatremia and may lead to an increase in intradialytic weight gains because of an inefficient removal of sodium, and so is not the preferred first step. There are 2 large meta-analyses that have supported cooling, as trial by Mustafa et al. From CJASN in 2016 and Selby in NDT in 2006. So we have some pretty good data suggesting this is the best next step. Question 7. A 77-year-old man is admitted with 2 to 3 days of nausea, vomiting, and constipation. On admission, he is noted to be confused and lethargic. His past medical history is notable for Crohn's disease, hypertension, congestive heart failure, coronary artery bypass surgery, and chronic kidney disease with a baseline creatinine of 1.6. On admission, he is noted to be hypotensive and bradycardic with abdominal tenderness, marked abdominal distension, and absent bowel spasms. His neurologic exam is notable for absent deep tendon reflexes and dilated pupils. Which of the following best explains the presentation? Hypokalemia, hyperkalemia, hypercalcemia, and hypermagnesemia. The answer here is hypermagnesemia. Over the course of 4 hours, his blood pressure declines, his bradycardia worsens, multiple pressors are required, and the patient becomes oliguric. He requires intubation. Imaging was notable for marked ileus and slight pulmonary congestion. His lab data reveals the following: sodium 143, potassium 4.3, chloride at 111, moderately decreased CO2 at 21, BUN 50, and creatinine 2.1. His glucose is 150, Calcium is normal at 10, phosphorus is 3.1, and his magnesium is markedly elevated at 8.9. Treatment for this patient should include A, dialysis, B, a calcium infusion followed by dialysis, C, saline-infused furosemide, or D, CVH. The answer here is calcium infusion followed by dialysis. This patient has severe hypermagnesemia. The symptoms are characteristic: nausea and vomiting, itis, depressed reflexes, decreased parasympathetic tone reflected by the dilated pupils, paralysis, apnea, and respiratory depression, bradycardia, QT and PR prolongation, low blood pressure, and ventricular fibrillation and bradycardic arrest as the endpoints. Most filtered magnesium is reabsorbed, and so their toxicity rarely occurs except when magnesium administration is combined with renal failure. The vast majority of people can get rid of as much magnesium as you can give them. And so this really only occurs in people who've got an inability to excrete magnesium efficiently. Mild toxicity occurs when the magnesium is less than 6, moderate when it's 6 to 10, and severe when it's greater than 10. Interestingly, toxicity is much more common with oral and intravenous magnesium, probably because we don't get such large doses of intravenous magnesium to patients. But we do see this in patients who are chronically taking oral magnesium supplements and have chronic kidney disease. Severe symptoms have been described with levels between 6 and 10, and bradycardia and hypertension are actually not unusual at this level. Mild toxicity, so patients who are relatively asymptomatic, can be treated with fluids and diuretics to promote excretion. Dialysis is definitely indicated in severe cases. In moderate cases with evidence of significant complications, or when renal failure is present and you're unable to remove the magnesium by diuresis alone, CVH is probably too slow to be useful in moderate or severe cases. And so at least initially, the patient should be on hemodialysis. The reason why we give calcium to these patients is if there is cardiac toxicity present, magnesium blocks the calcium receptors, and so giving calcium can help reverse some of the cardiac complications of the disease while you were trying to get the magnesium levels down with dialysis. So at least initially, I would give a calcium infusion to this individual and then start them on dialysis. Question 9. A 72-year-old hemodialysis patient presents with fever, chills, and positive blood cultures for Staph aureus. He dialyzes via a right internal jugular line. His medical history is notable for a defunct right and left upper arm fistulas and a stenosis of the left internal jugular and subclavian veins. His temperature is 38, heart rate is 100, and his blood pressure is 140/90. The patient looks uncomfortable but not toxic. What is the appropriate management? A, immediate removal of the line and vancomycin for 3 weeks. B, vancomycin for 3 weeks without line removal. C, vancomycin for 3 weeks with exchange of the line over a wire in 2 to 3 days. Or D, gentamicin lock and intravenous vancomycin for 3 weeks. So I think here it's really important to recognize that this patient has very few options for access, given that he has defunct right and left fistulae, and also a stenosis of both his left internal jugular and subclavian veins. So the answer here is vancomycin for 3 weeks with an exchange of line over a wire in 3 days. However, over 48 hours, the patient develops a pressure requirement and continues to spike high-grade temperatures. What now is the most appropriate step? A, an echocardiogram to rule out endocarditis. B, pull the catheter and dialyze via a temporary catheter until clinically stable. C, add gram-negative and fungal coverage. Or D, a citrate block. Well, the answer here would be yes, the patient does need an echocardiogram, but I would pull the catheter and dialyze via a temporary catheter until clinically stable. Currently, our practice is that in patients with line infection who are clinically stable, an extended antibiotic course is appropriate, and only treating through a line infection is definitely associated with high recurrence and incidence of complications, including endocarditis and endocarditis. Immediate removal is safe, but the problem with this is it requires temporary access. And so you may burn through access sites more quickly than a catheter lock or a guide wire exchange. And for that reason, what we suggest is that in patients who have a line infection, we do a guide wire exchange after 3 to 4 days once they've already received a number of days of antibiotics. This avoids the need for temporary lines and is actually associated with relatively high cure rates and lower current rates in non-randomized series. There is no randomized controlled trial comparing the two approaches to patients with line infections, but at least in these series, the recurrence rate is less than 10%. However, you have to remove the line. The patient develops signs of severe sepsis, hemodynamic instability, persistent bacteremia, metastatic infection, any pus at the exit site, or if the patient has Pseudomonas or Candida. If after the exchange, the blood cultures become positive again, similarly, the line would have to be removed. Question 11. A 35-year-old man presenting with acute flank pain and is noted to have non-obstructing 6mm calculus in the right ureteropelvic junction with several smaller stones. He's sent home from the emergency room with a narcotic prescription and told to follow up with a nephrologist, and I would imagine a urologist. In addition to analgesia, appropriate steps at this point include A, urology referral for lithotripsy, B, a 24-hour urine collection and metabolic workup, C, straining the urine analysis of any retrieved stones, or D, no workup is necessary in the first stone episode, and finally E, B, and C. The answer here is B and C. So the stone is probably going to be passed spontaneously given its size. So right now, the patient does not necessarily need to be referred for lithotripsy. And it's true that in patients who have a single stone episode, the recurrence rate is relatively high. It's about 50% at 1 year, 30% at 5 years, and 50% at 10 years. But about 50% of patients will never have a recurring stone. So you don't necessarily need to do a complete metabolic workup in patients in this age group who have a single stone episode. However, in this case, he doesn't have one single stone. He has one larger stone, which is symptomatic right now, but also several smaller stones. So this person has multiple stones and should have a metabolic workup. And you should also do your very best to get the urine, strain the urine and try and get an analysis of the retrieved stones. Metabolic workups are fantastic in trying to look at the risk for stones, but more than once I've been surprised by the composition of a stone in somebody who I was convinced had a very different kind of stone because of the metabolic status of their urine. So it's really important, most importantly, to get that urine, that stone sample if possible. The patient's medical history is remarkable for hypertension. His family history is negative for stones. His dietary history is unremarkable. His only medication is atenolol. Urinalysis and serum chemistries are unremarkable. His PTH is within normal limits. A 24-hour urine collection shows the following: volume 1.7 liters, calcium 400 milligrams per day, oxalate 45, citrate 150, urate 145, sodium 190, and a pH of 6. Which interventions should you recommend? Increase urine volume and start out urinal. Calcium citrate, increase fluid intake and decrease salt intake, or substitute hydrochlorothiazide for atenolol. At least initially, we should increase the fluid intake and decrease salt intake. As I said, the needful workup is equivocal after the first stone, but he has multiple stones and so should have a workup. Calcium oxalate is the most common form of stone, followed by calcium phosphate. A stone analysis should be performed wherever feasible, so the therapy can be tailored to preventing supersaturation of the urine with stone constituents. This patient's stone was less than 8 millimeters, and so these usually pass spontaneously without any intervention. His 24-hour urine volume reveals low volume, high calcium excretion, hypocitraturia, and a high sodium intake. In the first case here, I would increase his urine volume to greater than 2 liters as a cornerstone therapy. However, what we also know is that high sodium intake promotes calcium excretion. So it would be reasonable as a first step to have him decrease his sodium intake and repeat this collection in 4 to 6 weeks. I would also mention that if you put somebody with a very high sodium salt intake on a thiazide, then it is not going to be effective in reducing calcium excretion, and you are going to cause potassium wasting. So you will see hypokalemia rather than hypocalciuria. Allopurinol is effective in reducing uric acid levels in calcium in uric acid stone formers, but is not a first-line therapy, which would be to alkalinize the urine. Thiazides can be useful in decreasing calcium excretion and preventing recurrence, and citrate should be given in patients with persistent hypocitraturia. You should never give a low-calcium diet to a patient with calcium-containing kidney stones. Many of these patients have calcium wasting. And in fact, if you put them on a low-calcium diet, you actually might promote osteopenia and increase urinary oxalate excretion. So this is an incorrect answer. An 82-year-old man is admitted to the intensive care unit following exploratory laparotomy and resection of a perforation at the ileocecal junction. Over the first 4 post-operative days, his pressures are obtained and ventilation requirements are weaned. On hospital day 5, he became lethargic, hypotensive, and olivuric, and was noted to have intermittent atrial arrhythmias and ventricular ectopic. His abdominal exam is notable for marked tenderness, and his labs are notable for an amylase of 225, creatinine of 1.9, bicarbonate of 14, an NGAP of 18, and a CPK of 5,500. What is the most likely explanation for this patient's presentation? The answer here is propofol toxicity. Let's look at some of the distractors first. Propylene glycol toxicity can be seen with prolonged infusions of drugs like lorazepam, digoxin, and phenytoin, but is most common with lorazepam. It is not present with midazolam. Propylene glycol is the carrier for this drug and is the higher concentration lorazepam infusions and the other medications. It's osmotically active, renally cleared, and metabolized to lactate. Accumulation can result in osmolar gap, anion gap acidosis, and an osmotic diuresis. Can be dialyzed in severe cases. There are multiple potential explanations for this patient's symptoms, but pancreatitis alone is unlikely to explain everything that we're seeing, including CPK elevation. The patient most likely has propofol infusion syndrome, which is characterized by infusion, cardiac toxicity, pancreatitis, rhabdomyolysis, lactic acidosis, and kidney injury. This has a very high mortality associated with it. Risk factors include rapid infusions of propofol or prolonged infusion for more than 48 hours. The treatment is propofol withdrawal and supportive measures. All intensive care units these days have protocols to limit the amount of propofol administered to patients to prevent this syndrome from occurring. A 77-year-old dialysis patient complains of progressive discomfort in his arms and legs. Physical exam reveals the following. What is the most likely diagnosis? Scleroderma, calciphylaxis, beta-2 microglobulin amyloidosis, or nephrogenic fibrosing dermopathy? The answer here is, unfortunately, nephrogenic fibrosing dermopathy. And thankfully, we don't really see this very much anymore. This is characterized by diffuse hyperpigmentation or yellow brawny induration in the skin, particularly over the forearms and shins. It may be diffuse and progressive and may lead to disabling flexural contractures. The appearance is very similar to plaques of scleroderma, but the distribution is different and is not associated with autoantibodies. Biopsies demonstrate CD34 expressing dermal fibrocystic spindle cell proliferation with minimal inflammation. It is strongly associated with prior gadolinium exposure that should be avoided in patients with end-stage kidney disease. Although almost all of the cases, and not all of the cases, were reported with the original type 1 agents. And these days we use type 2 agents, which have been associated with very, very few cases. And so there are some people who would argue that it is no longer contraindicated to use gadolinium in patients with end-stage kidney disease. There may be a role for a dialysis post-gadolinium exposure, but it is uncertain. A 32-year-old woman is pregnant for the first time. Her past medical history is notable for bipolar disorder, currently controlled in carcomazepine. She's admitted 11 weeks of pregnancy with nausea and vomiting. Her admission labs are notable for creatinine of 0.5, sodium 133, potassium 4, and her exam is remarkable for blood pressure of 100/60, a heart rate of 70, moist mucous membranes, and particularly lethal. Nephrology consult is requested for evaluation of hyponatremia. What interventions should you recommend? A. Start homocysteine for volume depletion. B. Fluid restrict to 1.5 liters a day while waiting for urine electrolytes. C. Hypertonic saline. Or D. No therapy is necessary. The answer is that no therapy is necessary. The sodium level in this patient is normal for pregnancy, so no further testing is needed. Sodium levels decrease approximately 5 milliequivalents per year during pregnancy due to changes in the threshold for ADH release, reduction of placental vasopressinase, and changes in first threshold. Hypertonic saline is indicated only for severe symptomatic hyponatremia. The patient is discharged and has an uneventful pregnancy. At 38 weeks, she is admitted with vaginal bleeding. On review of systems, she complains of frequent urination and thirst. The serum sodium is 138 and her urine volume is 5 liters a day, which is the correct answer. This patient most likely has lithium-induced diabetes insipidus. Serum glucose should be checked to rule out pregnancy-induced diabetes. DDAVP is likely to be a better treatment than AVP, and a water restriction test should be performed. The answer is that DDAVP is likely to be a better treatment than AVP. The rise in serum sodium at this stage in pregnancy is suggestive of pregnancy-induced diabetes insipidus. The central vasopressinase increases during pregnancy, and at 22 to 24 weeks, vasopressin clearance is increased fourfold compared to pre-pregnancy values. Pre-existing diabetes insipidus may be exacerbated by this increase in vasopressin clearance. In a minority of patients, the increase in vasopressin may be exaggerated and cause de novo diabetes insipidus, that typically has an onset during the late second or the third trimester of pregnancy. Placental vasopressinase inactivates vasopressinase, but has no effect on the structural analog DDAVP. So in the appropriate setting, DDAVP is a good treatment for this because it will not be affected by the presence of the vasopressinase. It typically resolves within a few days of delivery. A 76-year-old PD patient is admitted with profound hypoglycemia. He takes 10 years of long-acting insulin twice daily and uses short-acting insulin meals according to the sliding scale. His wife states that the patient has been in his usual state of health. The exam is unremarkable at temperatures 38.6 degrees. White's count is 7 with a normal differential. Chest X-ray of normal abdominal imaging, urinalysis, and blood and urine cultures are negative. The most likely cause of hypoglycemia is A, a malfunctioning glucometer, B, a pulp infection, C, icrodextrin, or D, reduced insulin clearance. The answer here is icrodextrin. Icrodextrin is a glucose polymer that is metabolized in the circulation of lymphatics to maltose, maltotriose, and maltotetraose. Glucometers measure glucose based on enzymatic reactions such as glucose oxidase and glucose dehydrogenase, can actually cause spurious hyperglycemia when they're exposed to maltose and other icrodextrin metabolites. And so what can happen in this setting is that the patient using this glucometer thinks they're hyperglycemic, takes larger and larger quantities of insulin, and can cause an insulin overdose. Something similar can be seen in patients who are getting intravenous immunoglobulin infusions, which can also contain maltose. The 38-year-old man presents with slowly progressive azotemia, hypertension, as well controlled thiazide diuretic and a low-dose ACE inhibitor. His family history is notable for a mother who developed ESRD in her 50s on no etiology. He has no other medical history. His previous physical exam is notable for a blood pressure of 1/85. Urinalysis is bland. His creatinine is 1.7, urea is 38, potassium 4.2, calcium 9.6, phosphorus 4.3, and uric acid is elevated at 8.1. Protein to creatinine ratio is 0.45. He has small kidneys with a one simple cyst on the left. The most likely diagnosis is hypertensive nephropathy, polycystic kidney disease, sarcoidosis, or juvenile hyperuricemic nephropathy? The answer is juvenile hyperuricemic nephropathy, most likely type 2. This is caused by genetic defects in the uromodulin gene, or TAM horseful protein. It's associated with hyperuricemia, gout, and slowly progressive bland renal failure that first appears in the 35th decade and progresses over 10 plus years. The patients have small kidneys on ultrasound. Medullary cysts may be present at later stages, but are difficult to see on ultrasound, and proteinuria is generally low. Renal biopsy may show interstitial nephritis, but changes are generally non-specific on a standard biopsy. There is altered distribution of TAM horseful protein, but this is very difficult to detect. It is an autosomal dominant condition due to defects in the UMOD gene. Non-hyperuricemic forms of hereditary interstitial kidney disease include medullary cystic kidney disease type 1, which is caused by a MUC1 mutation. Gout is absent in these patients, and ESRD, the onset is between 20 and 70. And Renin gene defects caused by Ren mutations. Again, gout is later absent, and there are no medullary cysts, and onset is age 40 to 70. This, however, is associated with childhood hypoproliferative anemia and frequent hyperkalemia hypertension. Here's a straightforward question. What is the appropriate dose of CVH for patients with AKI? Greater than 2,000 moles per hour of effluent, greater than 35 moles per kilogram per hour of replacement, greater than 20 moles per kilogram per hour of replacement, or greater than 20 moles per kilogram per hour of effluent solution? The answer is D, greater than 20 moles per kilogram per hour of effluent solution. With convective renal replacement therapy, CVH, effluent is fully saturated. With respect to low molecular weight substrates, it's equivalent to saying the sieving coefficient is 1. This is thus equal to the effluent rate minus correction for any pre-dilution. Data that has been conflicting, but there have been a number of large studies, including Australia-New Zealand trial, the VA trial, and the Akiki trial, which suggest no benefit for an effluent rate above 20 moles per kilogram per hour. It should be said, though, that some of this may be due to the fact that there is large amounts of phosphorus removed during very inefficient dialysis, and this could have contributed to the increase in adverse findings of patients with the higher doses of dialysis in these trials. 71-year-old man with no significant medical histories in a high-speed motor vehicle accident, rupturing his spleen and injuring his bowel. He receives intravenous contrast for a CT scan while hypotensive in the emergency room and develops oliguric acute kidney injury. 3 days later, his urine output is increased to 1 liter per day, however, he remains intubated and his potassium is 7. Renal is cold in its hemodialysis. His platelets are 80,000 and his INR is 1.5. What is the most appropriate size and type of dialysis axis? A non-tunnel symptomia, B, a tunnel internal jugular, C, a non-tunneled femoral, or D, a non-tunneled jugular. I would argue here that the correct site is a non-tunneled femoral line rather than non-tunneled jugular line. Tunneled lines may reduce the risk of infection and may reduce risk for need for later transition to tunnel access with a second procedure in patients without infection and those with pre-existing CKD. But in somebody who's expected to recover relatively quickly, there's probably no need for an extensive procedure like this. Subclavian accesses are associated with high risk of being stenosis, so these should be avoided in patients who need temporary dialysis, even if they're expected to recover. There was a randomized controlled trial done in the late 2000s that was published in JAMA, which looked at the difference in infections for short-term placement to dialysis access in the jugular femoral lines. And turned out in these trials that there was no overall difference in the rate of infections unless the patients were obese, where the jugular site was preferred. There was no difference in efficacy rates between the right femoral and right jugular location. But interestingly, the rates of failure were much higher with the left internal jugular line. Femoral vessels, therefore, are equivalent to right internal jugular vessels in terms of infection risk and appropriateness for use in patients who are thin and need temporary dialysis. The other advantage to femoral vessels, they are more compressible and may be a better choice in coagulopathic patients. So this could be a judgment call. For my sense, at least in this patient, femoral line would be a better choice.